please help spread the message of frequency-specific microcurrent by clicking on the like button. You can subscribe to us on YouTube or any podcast app. If you have any questions, please leave them in the comments. You can find the podcast transcription at frequencyspecific.com, as well as more information about frequency-specific microcurrent.
There you are.
I'm here.
I'm so excited.
And in black and white, just as we are.
But this is blue, but it looks black.
Okay.
I get to go first.
Okay, so much to unpack today. So I just got your email. So I will let you introduce the wonderful news.
You got the email? Isn't that just, this is the IRS granting 501c3 status to the American Academy of Resonance Medicine. It has been on my to-do list for 3 years. And then there was George, and then there was Adam and the clinic. And finally, my lawyer retired in December.
Okay.
And I said, is this on your plate or mine? And he said, it's on yours. There's an easy form. I said, you need to help me with the easy form. He said, no, I'm retiring. So my new lawyer, I said, I will pay you to sit down with me because this form is not easy.
Okay.
Anyway, that was 3 weeks ago. And this is our approval. So this is not the Frequency Specific Research Foundation.
Yeah.
This is for all resonance therapies, I guess no matter what, and we'll have to figure out how to manage that. And you and Dave Burke and Ben Catholi said, yes, you would be on the board 4 years ago. And I'm sure you all forgot.
No.
And thanks to Candace Elliott, she was encouraging me persistently, you have to get this filed. And it's, hang on, I'll get there. Here it is. This means that we can accept tax-deductible donations. We need a treasurer, but we accept tax-deductible donations. And the charitable purpose of the foundation is to fund research on the effects of resonance therapies, including FSM, and as a secondary goal, to fund patient care for indigent patients and home devices for them, for patient treatment. We did it. Yay!
That is so exciting. And what a way to start the show off. So now I have nothing important to talk about anymore. It is so exciting. And it's funny because one of the topics I wanted to talk about today was how we talk about FSM. And a lot of the questions I get asked are, how do you explain this to a patient, an athlete, a doctor, a surgeon, a person you meet in the street? And there are so many different ways that we can explain what we do. And then the next step or the next kind of questions, are there any studies, or depending on who you're talking to, and having a board and having an organization like what you just mentioned, it just brings so much more credibility to those of us that are in the field. So this is a super exciting moment.
I had a research foundation. I made somebody else president of it in 2011. We were approved as a 501c3. And then things happened and it was rescinded when the president didn't file the taxes. So I've been waiting since 2012. So 12 years to do it again. And so here we are. And it's really interesting that you would come up with that. How do we explain what FSM is? Because that question has come up for the website in conversation like a lot in the last week. And the explanation I have seems to be one that makes everybody happy. So I'm going to throw it out there and see what you think about it. Getting it concise is tricky, but the easiest way to explain it is human cells or cells in your body have receptors on the outside that respond to drugs and nutrients like a key in a lock. So the receptor is like this, and the pharmaceuticals like Advil and supplements like vitamin C land on those receptors, change how the inside of the cell works, and changes what the cell does. Frequencies act like your key fob, like the frequencies from your key fob, changing that receptor with a frequency instead of a chemical. Now, sometimes you need both, but if you used your key fob to open your car door today, you have used a frequency-specific technology to change a receptor from open to closed. And that it just takes it all away. If they want to go on, then there's cell physiology and kinases and messenger DNA and messenger RNA and microRNA and cell responses and infection and blah, blah, blah. There's way more detail for medical providers. Are there any studies? Of course there are. We have animal research and human research showing that one frequency to reduce inflammation reduces inflammation better and faster than any prescription or non-prescription drug ever developed. Really? Yeah. And then the rest of the papers that we have published are all in clinical cases for applications of different frequencies in clinical situations, like delayed onset muscle soreness. And then, depending on who you're talking to, you can say, I will say to a medical audience, this control trial, placebo-controlled trial on delayed onset muscle soreness, had an N of 22. And the p-value has 2 zeros and a 5. And you can tell who in the audience understands statistics, because that's impossible.
Mm-hmm.
With a prescription drug to get a p-value of 0.05, actually it's 0.3 zeros and a 5. For a prescription drug to get a p-value of 0.05 takes close to 1,000 patients. It's a huge N because of the way the math is done in statistics. Yeah. So FSM is easy to do research on because the changes we get are so big with such a small number of patients, even in a control trial. So what are you good at? That's where the guest list gets long. Mm-hmm. And the plural of anecdote is not data, which is why we bribe people to produce case reports. Now we know that we have a protocol that reduces the risk of breast cancer in patients with fibrotic breast tissue, reducing it in 8 sessions from a class 3 to a class 2. It's an N of 1, mm-hmm. But it's just a huge response. So there's more papers coming. I'm so excited.
And that will continue the conversation. Again, going back to the key fob and
analogy.
Totally. It's enough information for a layperson to wrap their head around the fact that the mechanism of action is something that you don't see and you don't feel, yet it is effective, right? So lock, unlock, big forerunner, little fob, it works. Those of us who work with athletes run into a whole other stumbling block because I feel like they don't need the how does it work? Why does it work? It's you fixed my friend, you fixed my teammate uses this machine, I want the same. But the question typically is, how come I don't feel anything?
Oh, that's easy.
Yes, you with the beautiful white pearl necklace.
What do you tell them?
So I explain the key fob. We talk about the analogy with the opera singer singing the note. So we talk about the mechanism, how scar tissue almost vibrates apart. I use the bridge analogy depending on who my audience is. But for athletes that have multiple games in a week, so football players don't necessarily care about this so much because they just play for Sunday, they live for Sunday. So they have 6 days to get hit by a Mack truck and then repair before game day. But if you have an athlete that is playing 3 times a week, they are not afforded that luxury of an elbow in a piriformis or a contraption. So I explain the benefits of not necessarily feeling anything because it's preserving the superficial tissues on top of the deep. And so that sometimes is enough. And then I'll walk them through the fact that you will feel it, but you will feel it in a different way. And the athletes are so kinesthetically aware that they'll feel it in a different way. But you tell me what.
The one I use with athletes is the reason you can't feel it is the microcurrent uses the same kind of current that your body produces on its own, but it increases energy production in the cells by 500% in 30 minutes. So it gives you 5 times the energy you had when you walked in the door to repair the tissue.
Yes,
We
absolutely.
have frequencies that reduce inflammation. I got data on that. You don't want to know about it. And they understand energy.
Absolutely. And when I bring up the fact of if they like the big TENS machine or they like the big PEMF that is very threshold, all
So
works the same. However, and then I bring up that point that you were saying, I said, when you're working at amperage at that level where it's extremely sensory, you are decreasing energy in the cells. So
Yeah.
it is sub-threshold. You have the ability to increase energy. And that typically is enough for any athlete, for any of us that are even weekend warriors. More cellular energy. Yes, please, I'll take 2.
And it's physiologic. Your body can use it. If you blast it, your body says, no, thank you. Ow, that's too much.
Right.
You want to slide right in so your body won't resist.
Exactly.
And then the frequencies just change how the tissue operates.
Right.
So that it doesn't hurt. Yeah. So
I had a question the other day. There's like a group that come to see me, different athletes, and they all switch off. And one of them said, did you ever think that your results are just because you're a really good manual therapist and you do really good corrective exercise prescription? For sure. And I said, oh, I know I'm a really good manual therapist and I am really good at corrective exercise. However, I was doing that before FSM. And once you feel change happen so fast, you can't unsee it, you can't unfeel it. So I said, as good as I am, I know that this helps what I do with the tissue. And I know when patients treat themselves at home, so that everybody that has custom cares for home use, when they're still getting benefit and I'm not in their house, then that comes to me programming the machine correctly. And that's something else that I want to circumvent about today is the mode bank prescription versus really tailoring a prescription for somebody. Yeah. And to me, that is the most important thing. So yes, I couldn't work without my precision care. No, I couldn't work without a custom care, but the most important part is the software with that custom care that enables you to customize, adapt, pivot.
Yeah.
Because if you're doing your job as a clinician and the therapist is doing their job by using the machine as they should, that prescription should be continuously changing.
Yeah.
If we're on the right track, if we're healing, and that brings me to my quote really quickly before I get totally.
What do we have a quote?
Healing doesn't mean the damage never existed. It means the damage no longer controls your life.
Oh, yeah. Amen.
And that's going to bring me back to another set of words pretty soon. But okay, I just unpacked quite a bit there. But I want to give people tools. I want to give patients the right phrase to talk about FSM in the right way. And I want to give clinicians the right phrases, because we are in so many different fields: veterinary medicine, chiropractors, PTs, surgeons, rehab, nurse practitioners, like acupuncturists. There's so many of us that are using this. And I think, but we universally have to have the same message. So again,
This message, the thing we know for sure, and I like to stick to facts. When people get too airy-fairy about resonance medicine and frequencies and harmonics, whatever. I'm data-driven. And so what we know, what we have data about, is the current by itself increases, you have to say cellular energy because people don't know what ATP is, increases cellular energy by 5 times. You don't have to work for it. It just gives you free energy.
Yep.
The frequencies, the data we have says that the frequency to reduce inflammation reduces inflammation in animals and humans better than any prescription or non-prescription drug ever developed. The other frequencies, I don't have a lot of data on, but clinically, those frequencies seem to change how different pathologies affect the cell. Right? And then that just depends on what they want to know, how much they want to hear, where they're coming from. Are they a medical physician? Are they a surgeon? Are they if they're a naturopath? And what they're interested in is treating the GI tract, right? So I have a patient with irritable bowel, Crohn's, SIBO, small intestine dysfunction. So if you can reduce inflammation by a factor of 10 times in 60 minutes, and you can increase ATP production in the small intestine by 5 times in 30 minutes, and if you can improve the function of the vagus nerve to control inflammation, control digestive motility, control the microbiome, if you can do all of that, how much easier is it going to be to improve the patient's small intestine? Now, the other, and I lectured to a group of naturopaths a while ago. The key phrase for them is FSM buys you compliance. And they go, oh. It's like you think about your patient encounter, you take their history and you palpate their abdomen, and it's tender and it's bloated and it's uncomfortable and their pain levels of 4 or 5. And you then look them straight in the eye and you say, okay, I want you to remove these 6 foods from your diet. And I want you to take these 5 supplements. And in 3 months, you're going to feel better. And you watch the patient's eyes glide over, and you can see the little bubble forming over their head saying, oh yeah, sure, see you, bye. But you do the history, you palpate their abdomen, and then you say, would you mind if I tried something on you? You won't be able to feel it. And I just want to see if it's going to change how your abdomen feels. And then you run frequency for inflammation in the small intestine and plus encapsulated. And you run basically the small intestine protocol, even for 20 minutes. Their pain goes from a 5 to a 0. The bloating goes down by even 50%. And they get kind of floaty. And then you sit them up And then you tell them, okay, I want you to take these. Let's start with these 3 foods. I want you to take them out of your diet for 6 weeks. And I want you to take these 2 supplements. And I want to see you next week. They're out of pain. They now believe you. And they will do what you say because you created an immediate change. It's actually the same thing with athletes.
Mhm.
You have somebody with scar tissue in their subscap or their hip or their gastroc and soleus from a fracture or whatever, an injury. And you change the scar tissue and the range of motion. And then you tell them to do these exercises. What's your compliance like?
Yeah, it's fantastic.
Yes, ma'am.
Right.
Because there's a right now change.
Right. And I think that's when we start getting the questions of, you have a patient that has this big, long history and you have to treat 1,000 things. And where do I start? What's going to get them out of pain? That you have to treat the mold and the
vestibular injury and the.
Yeah, absolutely. But public enemy number 1 is always what's going to get them out of pain right now. Don't do that in treatment 1. You may not get treatment 2. It is complicated and overwhelming at times when you see the patient history that makes you want to just put everything down and say, I'm going to go home.
I'll catch you next time.
But we can't do that. But again, if you can just, again, boil it all down, and we talk about pattern recognition and we talk about following the breadcrumb and all the other things, just getting them out of pain. And so whether that's running concussion or treating the nerve or something.
Supine cervical practicum is bread and butter.
Yes.
I have a case that came in this week.
Do it.
Can I do that?
Yes.
Okay. Because our first claim to fame was 40 and 10, was the 47 cases that I took to IFM, the 30 cases that I took to NIH, and the cytokine research, and 58% of fibromyalgia caused by spine trauma recover from fibromyalgia in 3 months. That's data. We got that. All right. So I had a patient come in this week that her history goes back to the age of 15 when she had a viral infection in her inner ear, dizzy and hearing loss and tinnitus and all that. But then you go through the timeline and there's this 30-mile-an-hour head-on T-bone accident in 2005. And she is a fibromyalgia patient, but her pain level is now a 4. And I said, what was your pain level in 2000, whenever that was, 5? And she said, oh, it was a 7. And I said, it was a 7. She said, gradually over about 10 years, it got better. Okay. She said, but I'm still sore to touch everywhere and I don't sleep. And she's on good medication, nothing stupid, things that help. She's a medical practitioner, so she understands how things work. And I've never seen one. All of the fibromyalgia from spine trauma that I saw and treated were acute. Their pain level was an average of a 7.3, right? They were acute. The spinal cord was inflamed. Her disc recovered. The spinal cord remyelinated or scarred over or repaired. And she still hurts all over. So I tested the tender points at the beginning of the treatment, the second day, because the history took 3 hours. The second day, did the tender points. They were tender to 2 and 3 pounds per square inch. But she's centralized. When you've had a level 7 pain for 10 to 12 years, your thalamus amplifies pain. We have a frequency for that. From neck to feet, I ran 40 and 89, the same thing we do for thalamic pain, for central sensitization, quiet the thalamus. And she said, yeah, and my legs are always so tight. And down by her knees, her hamstrings are tight, her quads are tight, her pectineus and brevis is tight. We know that's loss of descending inhibition. So you increase secretions in the spinal cord. So I had 2 machines on her from neck to feet, increase descending inhibition in the cord, and quiet the thalamus. And then I just worked on her neck. Now she's got this 5-6 disc bulge that has to be pressing on the motor pathways in the center in order to get her legs to be tight. So I took the supine cervical practicum and I focused on the upper cervical facets. I didn't do the whole thing. And then I spent the last 20 or 30 minutes on just torn and broken in the disc annulus, because her major pain complaint is in between her shoulder blades. So she gets up off the table. I said, what's your pain level? And she said, I don't have any. My neck's a little sore, but that pain between my shoulder blades is gone. I said, yeah, I treated the disc. And then we tested the tender points, and she went from 2 and 3 pounds per square inch pressure to 5 pounds in 60 minutes. It's the first time in 30 years I've ever treated anybody that was chronic fibro. And she'd been treated by another FSM practitioner that did 40 and 10 that should have worked. They did 40 and 89, but they didn't run it long enough, and they didn't combine it with the treating the disc. The things that bothered her were the pain between her shoulder blades coming from the disc annulus. So what you said is absolutely, you have to treat what's bothering them.
Yeah.
It was like, it made yesterday so much fun.
Just hearing you, and this is why I love the podcast. And I love doing it before it was a podcast, when it was just you and I that chatting during COVID all the time.
Yeah.
But sometimes when you say it out loud and you teach it to somebody, you hear it in a different way. And these are all messages that we've heard for so long, but you explaining it just reminded me of when we're talking about the first couple lines in the concussion protocol. And I believe that, and I don't know if it's still like this in the core, but the phrase was, if you've ever applied a Band-Aid to a screaming toddler, you get this, right? It's just calming the situation down. And then once it's at a certain level, then all the dominoes start going. So again, if you can hit the pain right away, even if you know there's a whole other land that you need to investigate, it just taking that activity, right? We talk about all the time with athletes, we're like, you're here and I need you out of here. So it's reversing it when you're dealing with somebody who's in, especially who's been in chronic pain. And for someone who's been in chronic pain for so long, it's just bringing it down to a level of that state of confusion that they're in because they've been in pain for so long, and they search for it. But I think running 40 and 89, like you said, if you're running it long enough and you're running it during the treatment, that really expedites absolutely everything.
That's what was wrong with her. She was centrally sensitized. But the thing that made the huge difference, honestly, was the education part of it. So she said, just pain right up by my bra strap. That's coming from the disc. And I keep the Cloward diagram.
Yes.
On paper, and I showed it to her, and she said, oh, it's my rhomboids. It's like, no, it's the disc.
Yeah.
What activities make the pain between your shoulder blades worse? Oh, when I work at the counter. Aha, what are you doing with your neck? For 20 years, she's had fibromyalgia. Nobody ever told her it was coming from the 30-mile-an-hour head-on collision or
Right.
T-bone,
Yeah.
and that it's from the disc bulge in her neck and the facets in her upper neck.
Right.
Both, I showed her the referral patterns for both. They both land right at your bra strap. And she comes in, her whole body is tender. That's the central sensitization. That's the thalamus. Her whole body is tight. That's 81 and 10.
Yeah.
and torn and broken in the disc annulus and inflammation in the cartilage.
Right.
What's making her bra strap hurt. So you do all three of them at one time, and she gets up off the table going, excuse me? I love my job.
And you've broken it down. And of course, when you reverse it, it makes so much sense. What you explained makes total sense. And I think especially when they've tried what should have worked, the 40 intense, that practitioner that ran 40 and 10, that should have worked like that. You're right. But again, speaking of when you take it one step further, the whole, and like you explained with the history, it is 40 and 89. It is the thalamus that's creating.
And then telling her where it came from. So
Yeah.
she comes in with this foam mattress that she carries with her because it hurts to lay on a chiropractic table. It hurts to touch her. So she carries this foam thing in with her. And as she's packing it up, I've already told her, you don't get to do anything with your arms out in front of you, elbows at your side, and you don't get to bend your neck. So she rolls up this foam mattress and she's bending her neck and she's got her arms out in front of her. And he reached over and I grabbed her arms and I said, no, this is how you do this. And then I showed her, elbows at my side, roll up the thing, and you keep your neck straight. You don't have to look at it. You know where it is.
Yeah.
And you do this. And she went, I said, your pain is not coming from space. It is this thing in your neck.
Yes.
And it is fixable.
Yeah.
There's hope here.
Yeah.
It's just, I love the job.
I'm going to go back to the ugly face that I made and the eye rolling and the hair pulling for a second.
Okay.
That's what happens when someone says tight rhomboids.
Oh God. Yes.
And I understand the patients that come in with it because they've been told that by typically a massage therapist.
Or a physical therapist.
Yeah, or physical therapist, because that's what they're doing with the muscle. But I'm going to even disagree with that because the rhomboid, like the trigger points in the area or localized area of contraction, or however you want to say that, are typically deeper, and they're running on the paraspinals and the iliocostalis thoracis, which are on top of the ribs.
And the longismus thoracis, which are innervated by C5-6.
Thank you. Muscles, we talked about this last week. Muscles can't push, they can only pull, they can only contract. And your rhomboids, when they're doing their job, retract the shoulder blades. And so if your rhomboids were tight, you would come into the clinic with retracted shoulder, and nobody comes in like that. So your rhomboids are perpetually elongated because we're slouched and we're flexed forward. And so they're getting longer, and little slips of them may try to contract, but they don't. And those little areas can get tight. I'm not debating that. So trigger points can absolutely happen there, but they're not creating the pain and they're not creating the dysfunction, is what I'm getting at.
Thank you very much. Exactly.
So this actually is a good segue to unpack a question that we got emailed to us, because there's a lot in the question that I think is very fitting for today.
Yes.
The question says, unsure on how to prioritize order of treatment when someone presents with disc and or facet inflammation and probable ligament instability from their mechanism of injury. So the example is whiplash. And the person continues to say, as the subacute and chronic disc and facet protocols in the mode bank contain scar frequencies, and these, if I understand correctly, can worsen ligamentous instability, which does one treat first? 24-100, so torn and broken in the ligament, and avoid scar frequencies until the ligaments are repaired? Or can one treat ligamentous instability and scarring simultaneously? In the core, it says, prepare for worsening if using scar frequencies when ligaments have been injured. But what about if someone presents with psoas adhesions and a ligament tear in the knee, for example? Should the psoas treatment wait until the knee is completely healed, or is it enough to run 24-100 on the knee while treating the psoas? So lots to discuss really quick.
I'm going to let you start because I know what I would say. So if you have a ligamentous injury in the knee, where did it start? If they took a hit in soccer and actually damaged the ligament, that's one thing.
Yep.
But is it postural and gait related? So the real question, is there any way to repair a ligament in the knee if the psoas is short and tight and the knee, because the hip is internally rotated and flexed, therefore the knee is going to be valgus? Are you ever going to be able to repair the ligament in the knee until you fix the psoas? So you have to think in your world, you think about everything is connected to everything. So in my world, you treat the psoas. Is the psoas ever the psoas?
No.
It never is. It's always scarring in the ureter, scarring in the kidney, sclerosis in the fat pad. If somebody's got a 27 degrees scoliosis in the lumbar spine, then the psoas might be actually the psoas. But
Right.
for most people, it's the ureter and the kidney. So you treat that first. Is that going to damage the knee?
No.
I don't think so, because am I treating scarring in the ligament? No, I'm treating scarring in the ureter. Well, different frequency. And if the frequencies are as specific as they appear to be, then I'm not going to hurt the knee. Now, if you have two machines, you can multitask. You wrap a towel above and below the knee, and you run 124 and the meniscus 214, because there's no way to damage the ligaments without damaging the meniscus.
Yep.
So you run that while you're working on the psoas. Then as the femur unwinds and allows the knee to be straight,